Hello everyone. I bring you another video of this diabetes series that I'm creating for you guys. This time is video 2, and it's going to be talking about the insulin and oral antidiabetics. So basically the medications for diabetic patients. So if you're looking at introduction or an overview on diabetes, I have another video, and I'm also doing one on complications. So search through the YouTube and you'll find it's a series of 3. So let's get started. So diabetics, as I mentioned in the overview of diabetes video, is a condition where patients don't either produce a lot of insulin, or the cell might not be taking the insulin because it's lacking receptors. So for type 1, they either don't produce anything or very little, not enough to make it work. Or in type 2s, maybe they're not producing enough. So we need to help them, especially in type 1. We need to help them with this insulin, which is the key to allow glucose to come into the cell. So for type 1 diabetics, they're going to get insulin with every meal and at bedtime. So usually 4 times a day. They could potentially have an insulin pump implanted in them that kind of just the patients press how many units for the pump to deliver. And in type 2, they could use insulin, and sometimes they don't require insulin. As the disease gets worse, if they don't make lifestyle changes for type 2 diabetics, then they might require some more. So in type 2 patients, they might get maybe once or maybe just with meals. It depends on the patient, okay? So the first thing that I want you guys to write down is that there are 4 types of insulin, okay? Well, not types, but in a way, classification. Well, yeah, we're going to call them types of insulin classification. So rapid acting, short acting, intermediate acting, and long acting. Yes, there is some insulin that it's combined with, could be 2 of these. So for example, like a rapid and an intermediate, or just, long with something else. But these are your 4 classes or type: rapid, short, intermediate, and long. Now, the next thing that I need you guys to separate is the onset, peak, and duration of each insulin. So what is the onset? Because a lot of people get confused with this. So let me just kind of clarify. The onset is when the insulin starts working. You're going to ask yourself, when is this insulin going to kick in, like, and start working? That's the onset. The peak time is when is the client most at risk for experiencing hypoglycemic events. What basically kind of like the peak of a curve, when the insulin or the medication is at its best working state. Now, the duration, it's how long is this medication going to be in the patient's system? Okay, so you need to know each type of insulin. You need to know for each type their onset, peak, and duration. In your book, in page 1114, there is a chart that basically says all of this and kind of goes over it, but I'm going to kind of break it down a little bit for you guys. So for your rapid insulin, you have Humalog or Novolog as a type of rapid insulin. Think about rapid, it acts really quickly. So the onset is 10 to 30 minutes. It reaches its peak at 30 minutes to 3 hours, but it lasts 3 to 5 hours. Now, on your short acting, the common one is regular, or it's called regular. Your onset is 30 minutes to 1 hour. It peaks at 2 to 5 hours, and the duration is 5 to 8 hours. Your intermediate, it's called MPH. It's cloudy. You're going to identify it because it's cloudy. And their onset is 1.5 hours to 4 hours, peaks at 4 to 12 hours, but it lasts 12 to 18 hours. In the long acting, commonly called Levemir or sometimes Lantus, the onset is 0.8 to 4 hours. It does not peak, and it can last between 16 and 24 hours. I will advise you to create this chart, memorize it. There's no magic way around it. There is some mnemonics that you can use, and I will provide those in my resources. But pretty much this is something that you need to know for the exam, you need to know for NCLEX, and you need to know for the rest of your career. Okay, so just memorize it. Find a way to memorize this times and names. A couple of other things that I want to let you know about insulin is that regular insulin is the only insulin that can be given IV, and usually it's combined, like I mentioned earlier, with some intermediate. Let's see. What else did I want to tell you about it? Rapid insulin, like Humalog, is the one that you see most in the hospital. And usually patients get covered with either Novolog or Humalog for their meals and also for bedtime. Now, in the long acting, because it does not have a peak and it can last 24 hours, this one, you might have a patient getting it at night. So it kind of works a little bit through the night and then covers them in the morning. So you might have some patients on, let's say, some Humalog and long-acting Levemir, in the day. Okay, here's an easy kind of just a visual, but again, the times are wrong. So please, make sure that you get the table from your book, page 1114. Where do we inject insulin? Well, it's given subcutaneously. So in the fat, we have most fat in our belly, and that's the best absorption site for patients to receive it. However, you can give it in the back of the arm, buttocks, and thighs. Your only medication or insulin that can be given IV is regular. Be careful when patients are exercising and they're getting their insulin in their thighs. So be conscious of that. Educate them that it is a fast absorption when the muscle is being worked. Rotate the sides because you get this lipodystrophy of the tissue. So you want to rotate sides. You can inject 90 degrees if the patient has good subcutaneous tissue or fat in a good size. But if you have a skinny person that doesn't have as much fat on that area, you might have to adjust your angle. For example, 30 degrees, 45 degrees. Insulins come in vials, and or also pens that are pre-filled already, and they just kind of dial. Is for that combination insulins that I was telling you earlier. The vials in the hospitals can be multi-use, like multi-patient use, or sometimes it's just one vial per patient. They do have expirations. Some need to be refrigerated until use, and then they could be out in the room temperature. Others need to be room temperature always. Uh, Insulins don't like extreme weathers. They don't like, for example, for you to freeze them. Neither they like really, really hot weather. So don't leave them in your car. Don't put them in the freezer. So they're sensitive to heat and freeze. Typically in room temperature, they can last up to 4 weeks. And on used ones, they need to be refrigerated. There's a picture of a pre-filled kind of with a dial pen, and the other ones, your vials are your normal insulin vials. Also, I want you to be aware that insulin or anti hyperglycemic agents that we're going to talk next um, can interact or sort of have a opposite reaction with some medications. So, for example, when we discuss patients that take a beta blocker medication, you have to be cautious because beta blockers slow the heart rate down. And so, if someone is experiencing a hypoglycemic event, they're not going to get the tachycardia that normally they do experience. So, we do want to educate that to the patients. When patients are sick, you have to, in a way, adjust their insulin schedule, or you have to educate for them. So, whenever they're sick, they never want to skip a dose. You want to monitor their blood sugar and see if they need more or less. For example, if they're going through a lot of stress or an infection, they might need a little bit more of insulin. Um, they need to drink a lot of water, rest as much possible when they're sick, and contact the doctor or PCP if they're, for example, not eating or vomiting. That way, the insulins can be adjusted. So that's a kind of overall summary. Really read those pages in your book so you can fill in the blanks of whatever I did not say. On the other hand, your oral antihyperglycemic agents, there are 5 categories, and they're listed here. I'm providing you a table that I'm going to switch here shortly the screens, and we're going to go over them. But there are 5 main classes. I know your book talks about these other classes, but we kind of concentrate more on the most common classes, and they're in page 1119. So let me very quickly change my display so you can see this table. And this table is going to be provided for you guys in your resources. So no need to write this down, okay? I'm providing it for you. So let's switch screens. Okay, bear with me for just 1 second. All right, so you should now have in front of you the table that I'm providing with these main 5 classes. First class, and again, I know, and I'm sure I'm not the only one, we struggle with these names. They're not so friendly to pronounce. So just bear with me with the pronunciation. I'm not perfect. I try. But the more you practice and the more you say it, the easier it becomes. So first class is biguanides, Most common is metformin. It ends on formin. I kind of highlighted what they normally end on so you can pick it and kind of give you a clue. It is the most commonly used drug and kind of first line of treatment. It works by inhibiting the glucose production and also the sensitivity of the tissues to the insulin. It also helps you lose weight and, helps with the lipids. It does have some side effects that patients don't like, and a lot of the times they stop taking it because of these, and it's diarrhea, this GI upset every time they eat. You need to hold it 1 to 2 days before IV contrast and 48 hours after contrast. IV contrast is filtered through the kidneys and it's kind of harsh on the kidneys. So that is why we hold IV contrast. Not suitable for people with kidney, liver, or heart failure. The next class is sulfonylureas. They end in IDE, so IDE. So commonly glipizide, glucuronide, and glimepiride. They stimulate the secretion of insulin by the pancreas. So, and also the sensitivity of the tissues to the insulin. So careful with hypoglycemic here events, and also they can gain weight. The next class is meglitinides. They end in glanide. Stimulate insulin secretion as well from the pancreas. So careful with hypoglycemic events. They're more common. Not that every insulin or hypoglycemic agent can cause hypoglycemic, but it's more likely whenever they stimulate insulin in the pancreas. So anyway, so hypoglycemic, they also provoke or can have gain weight, and you do not take it without eating or 30 minutes before eating. The next one is aglycosidase inhibitors. They don't really end on anything, so maybe you could just kind of memorize one of these. They decrease absorption rate of carbohydrates in the intestinal tract. They're called the starch blockers. So they block the absorption of carbohydrates. You really need to take it immediately before eating, and it can cause gas, abdominal pain, and diarrhea. The next one is SGLT2 inhibitors. They end in glyphosine. They decrease renal glucose reabsorption and increase urinary glucose excretion. And this kind of happens in the, what do you call it, in the renal system. High risk for UTIs and infections. Most commonly can provoke hypoglycemia. And if there's a lot of pee, because they make you pee the sugar, then it could cause dizziness. The next one is hard to pronounce, guys. Thiazolidinodiones. Yeah, they're hard. But they end in diazone. This reduces the insulin resistance in the muscle and increase sensitivities to insulin sensitizers. It can cause edema, weight gain, careful high risk of bladder cancer, heart failure, and MI. And not last, we have the DPP4 inhibitors. These basically they do a couple of things here. So I listed all but they work with glucagon, the production of insulin. They deal with incretins. So yeah, they have different functions. But Careful with pancreatitis and allergic reaction for these DPP-4 inhibitors. And now, last but not least, the GLP-1 receptor agonists, they stimulate the release of insulin, they decrease secretion, and slow gastric emptying. They can cause hypoglycemia, nausea, vomiting, and diarrhea. So that is a sum up of your anti-diabetic agents. I will continue with another video on your complications.